Hello, everyone. Hi, welcome to the fourth rendition of the ASEAN ACHT webinar. Tonight, the topic is on pulmonary hypertension in congenital heart disease. My name is Dr. MC Leong, and I'm from the National Heart Institute, Kuala Lumpur, Malaysia. Today, we have a few heavyweights in congenital heart disease fraternity. We have our friends from Thailand, UK, as well as Malaysia, right? For the interest of time, we'd like to advise everyone to reserve your thoughts and your questions to the very end. We would like to cover the lectures and the case presentation before we proceed with the question and answer session. It will be at the end of the webinar. But feel free to post your thoughts, your questions at the chat box below, and we will forward it to the speakers and the panelists so that you can get your questions answered. Right, let's get things started. The first topic is on pulmonary arterial hypertension therapy in patients with congenital heart disease. To deliver this talk is my mentor, Dr. Gita Kandavelu. She's a senior consultant pediatric cardiologist at the National Heart Institute, Kuala Lumpur, Malaysia, and she's a director of the ACHT program in the said center. She's a well-published researcher, and she's also a local principal investigator for a few pulmonary hypertension trials. So without further ado, we'd like to pass the floor to Dr. Gita Kandavelu so that she can deliver a talk. Gita, over to you then.
Thank you, Leon, for the kind introduction and for the invitation to be part of this inaugural meeting. I would like to also extend a warm welcome to my friend and mentor, Professor Kostas, who's one of the world-leading experts in PAH in this region, and also to my friends from Thailand, another very esteemed faculty, and a very good evening to everyone. I'm going to share my slides. Just let me know if you can see them and you can hear me clearly. Everything good, Yong? Can you all hear me?
Yes, Dr. Gita.
Yes, okay, thank you. So good evening, ladies and gentlemen. These are my disclosures. In the 2018 6th World Symposium of Pulmonary Hypertension, the PAH guidelines were defined as a mean pay pressure of more than 20 millimeters mercury. And for the groups of PAH, there are 5. Most of our patients with congenital heart disease, as we're aware, are defined under group 1 pulmonary arterial hypertension. But there are those defects that have post-capillary pulmonary hypertension, and then this new group of patients in group 4, which have congenital pulmonary artery obstructions, and those patients with Fontan and the segmental pulmonary hypertension defined under group 5. It's important to define these patients clearly because the management strategies for these patients vary. But for the majority of the patients with PAH associated with congenital heart disease in group 1, it's further defined with a normal pulmonary pressures of less than 15 millimeters mercury. This is to rule out post-capillary pulmonary hypertension, and pulmonary vascular resistance of more than 3 Woods unit to rule out those patients with high pay pressures due to increased pulmonary blood flow and not fixed pulmonary disease. So PAH with congenital heart disease is further subdivided into 4 groups. So you have 1, the Eisenmenger patients, where there's frank reversal of the shunt. And then you have those patients with still significant left to right shunts, but have mild to moderately raised pulmonary vascular resistance. And those patients with pulmonary vascular resistance that are out of proportion to the defect or the hemodynamic shunt, group 3, and group 4, which are those patients that develop late onset pulmonary vascular disease following closure of the shunt. So group 3 and group 4, you tend to manage them as patients with idiopathic pulmonary hypertension, but these patients with group 2 pose a challenge in that if you leave them alone, they'll go on to develop Eisenmenger syndrome, but if you close the defect, they can develop late onset pulmonary vascular disease. So if you look at Eisenmenger syndrome, over the years, the management has been very well defined, but even then there has been an evolution. In the 2015 guidelines say that if the patients are in functional class 3, you can start bosentan class 1B, and you may consider PAH targeted therapy, combination therapy for those who deteriorated to B. But in the 2020 ACHD guidelines, they become a bit more proactive in that you now use objective 6-minute walk test to determine deterioration, and you start monotherapy. All combination therapy should be considered. It's 2A now for patients who deteriorate despite monotherapy. And then you talk about risk assessment and also supportive therapy like iron supplements and avoiding unnecessary venesection in these patients. Even though the studies in relation to randomized control trial are a bit limited in patients with Eisenmenger syndrome, the most famous one is the BREATH-5 study, but local registries and national registries have clearly shown that patients with Eisenmenger syndrome who are on advanced therapies definitely have a better long-term survival compared to those who are not. But how do we re-stratify these patients in terms of wanting to be proactive? So we all are aware of this ESC guidelines where they have these 4 subgroups where you have clinical parameters, objective exercise testing, then you're looking at RV function, biomarkers, and imaging, and hemodynamic data. And it's clearly defined here in terms of a composite risk score. So you know that if you start treatment and you can keep these patients in the low risk, then they translate to good outcome. And the French team has even made it easier that you just look at 3 parameters like your functional class, anti-proBNP, and your 6-minute walk. And if you can keep the 3 parameters in the low risk, this translates to good outcome. But for patients with Eisenmenger or congenital patients, this does not take into consideration cyanosis, iron deficiency anemia, and the heterogeneity of the defects. So the team from Brompton had put together this risk stratification table with worse and better prognosis, taking into consideration a lot of multivariate prognostic factors from evidence-based studies, again looking at the shunts, cyanosis, iron deficiency, and a lot more echo parameters based on studies that have been done. But the problem with using this table is that you can't really calculate a composite score to guide you, and patients tend to have parameters in both spectrums of the prognosis. So it's interesting that this team that was involved in the MUSES multi-center study looking at prognostic predictors for mortality in patients with Eisenmenger syndrome, they came up with this very nice table looking at multivariate analysis, prognostic factors like age, the type of shunt, the presence of pericardial effusion, oxygen saturation, and some univariate analysis. And here, if you plot the patient into this chart, you not only can guide you in terms of maybe initiation therapy or adding on combination therapy, but also gives you a probable 5-year mortality. So it's something to consider in risk assessing these patients. And we know in some of these patients with Eisenmenger syndrome, they can remain well for many years, like this patient of mine who's remained asymptomatic for the last 50 years. And even though data has shown that patients who are in function class 1 and 2 tend to have better long-term survival compared to those in function class 3 and 4, but there is this cumulative risk over time in terms of increasing mortality. So the question is, do we start or not start PAH targeted therapy in these patients? So the investigators of the Maestro trial tried to answer this question. This is a multi-center double-blind randomized placebo-controlled trial looking at macitentan in Eisenmenger patients. At 60% of the patients were in functional class 2. They also included patients who were on background therapy. There were some patients with Down syndrome and complex cardiac defects. But their primary endpoint was 6-minute walk, large multi-center trial involving 71 countries, and there was a hemodynamic sub-study involving 11 sites. It was a bit of a disappointment that the study did not meet the primary endpoint and results were considered null, negative, and there was no improvement of the baseline change of 6-minute walk in the patients who were on macitentan compared to placebo. But if you zoom down and look at the hemodynamic sub-study group, there shows evidence of improvement of primary vascular resistance in those with macitentan, and also improvement in the baseline 6-minute walk. And they it's not published, but they have the post open label study, and in the open label study they showed that 6 months to 12 months post macitentan, there was increase in the 6-minute walk in these patients with Eisenmenger syndrome. But the question still remains, do we or do we not start PAH targeted therapy in these patients with functional class 1? In this region, we still see a lot of patients who are referred late with simple shunts who have varying degrees of primary vascular disease. And the challenge is in deciding whether we close or not close these defects. And we know this increased shunt in patients with congenital heart disease trigger a progressive primary vasculopathy in the primary vascular bed. But there is this sweet spot where if you can timely close this defect, you may be able to reverse this primary vascular disease. But unfortunately, this is a multi-etiology, multifactorial disease. And despite all these multiple parameters, there's not one single parameter that can accurately define or tell us the timing or the factors that would contribute to reversibility of these shunts. So what did the guidelines say? The recent 2020 guidelines come up with these very nice algorithms for these 3 simple defects, looking at hemodynamic parameters, and I've summarized here. So for the group of patients with borderline hemodynamics, net shunt of more than 1.5, but with a PVR of more than 5, this is defined as a controversial group, and they say refer to expert center, or you may consider trial of PAH targeted therapy for the ASD patients with or without closure. Now, expert centers are centers where they need to not only have the expertise and the resource to come up with this very complex multi-factor or strategy in terms of algorithms to manage these patients, and they need to understand what parameters may determine long-term outcome, need to have strategies in terms of planning the pre-therapy or trial occlusion, and also more importantly, look at long-term outcomes and have bailout strategies. And we know because there's not one parameter that can clearly define the reversibility, there has to be a systematic approach, taking into consideration all these clinical imaging parameters as well as hemodynamic parameters. And even though the cardiac cath parameters are considered gold standard, it is not without its limitations. And acute vasodilatic testing, for all of us who do this in these patients, we know that even though they have come up with some guidelines, none of these predict the long-term outcome in terms of prognosis in this group of patients. So like everyone, we also have come up with our strategies in managing these patients. And I share with you our strategy for managing patients with atrial septal defect. So again, a comprehensive review of all the parameters, doing baseline cardiac cath, and then based on these borderline patients, we start PAH targeted therapy, review them after 6 months, repeat cardiac cath. But what we actually do is we again take these patients through a multidisciplinary consensus review by an expert team. And based on that, decisions are made in our center for these patients to go for surgical fenestrated closure of the defect. We have in the initial phase tried trial closure with the balloon and reviewing these patients with the device, but over time we have revised. So this is an ongoing prospective study. And over the last 7 years or so, we have 29 patients. And in this selected group of patients, as you can appreciate, there has been a drop in the pulmonary pressures, pulmonary vascular resistance, in the improvement in the right ventricular function and the functional class. But if you actually go down and look clearly and closely at the numbers, you can see that none of these patients actually really as a group reverted back to normal. So we have to be careful with these patients. And when you zoom down further and look at the numbers, you can appreciate that there are some patients in this group of patients that actually go on to develop accelerated pulmonary vascular disease, and 20% of these patients needed acceleration in their therapy within 1 year. So it definitely, there is a role for PAH targeted therapy in this group of patients to prime the pulmonary vasculature, but it has to be individualized to both patients and the defect. And to date, we really don't have an accurate way of assessing reversibility. And we choose to do this, we need to really base this on a systematic assessment of both clinical and investigative parameters. And the reliability of the criteria used are largely dependent on the experience of the gathered center. And these centers have to ensure that's good long-term monitoring and bailout strategies. But more importantly, if not sure, do not close the defect. I just also want to highlight another group of patients that we are seeing as these patients get older and have increased morbidity, where you have a combination of pre and capillary and post-capillary pulmonary hypertension in this group of patients. So the management strategies here have to be defined, because if you start PAH targeted therapies, you may put these patients at risk of developing acute pulmonary edema. So we do know that we are still closing some of these patients, either in childhood or even in the adult patients, and there is the risk of developing long-term PAH-targeted PAH and worsening of the pulmonary vascular disease. Hence, this really importance of having long-term survival surveillance and contingency plan. But in reality, many of these patients are lost to follow-up, and this is in from Brompton. Even in an advanced center, you have like 23% patients lost outpatient review. What more in this region where we don't have transition care in many centers, and multiple reasons for patients to default. So when embarking on this treat and repair strategy, I think it's also important to look at ensuring that there is good follow-up surveillance of these patients. So this German registry review of prevalence is really very nice, clean data. So they looked at simple lesions, and they found that there was a prevalence of developing late onset pulmonary arterial hypertension in these patients undergone closure at about 3 to 5%, 16 years post defect closure. Patients who had the defect closed later were at higher risk, hence timely closure of the defect, and this cumulative risk over time, hence long-term follow-up. But what was interesting, that only 28% of these patients were on PAH-targeted therapy. So we know there's this cumulative risk of developing late onset PAH pulmonary arterial hypertension in these patients, and also that even in simple defects, they can go on to develop late onset pulmonary vascular disease decades after closure. And why is all this important? Because this is a single center from Italy, and this is a Spanish national registry. This subgroup of patients post-closure have the worst outcome in terms of survival compared to the other subgroups of pulmonary arterial hypertension and congenital heart disease. So these patients, the strategy of management is as per idiopathic pulmonary hypertension, in that we know that in these patients, there will be a period where they are asymptomatic, but there is already underlying progression of the disease that is occurring. Hence, when they present to us, we have to be very proactive to risk stratify the patients and start or initiate early treatment before these patients go down this slippery slope and end up with right ventricular dysfunction, RV failure, and eventually death. So we use the risk stratification table. The ESC guidelines is easy to use. You plot in all these parameters and then you calculate a risk. And in this patient of ours here, you can see that's intermediate risk. And if you use the simple French registry of the three factors, you find that the patient has 0 criterion, low risk. You can also use the reveal calculator score, which is a bit more comprehensive and takes into consideration things like hospitalization and renal profile, which are actually important prognostic parameters. And then once you have determined the risk, based on the guidelines, you either start monotherapy for low risk, consider either sequential or upfront combination therapy. And for the high risk patients, maybe upfront combination, or even if you have access to IV treatment, maybe that should be considered. It's important to note that risk stratification is a dynamic process and hence should be reviewed and re-stratified every 3 to 6 months. Everyone is familiar with this pathway, but the question is, do the patients post congenital heart defect closure behave the same as the idiopathic patients? And in these large multi-center trials that have been done, there are this small percentage of patients who are post congenital heart defect. And in the more recent morbidity mortality trials, especially the Serapin trial, about 8% of the patients had post congenital heart defect, and they've clearly shown that starting macitentan in these patients actually had good reduction in primary endpoints in terms of morbidity and mortality. And similarly for the Griffin trial, selesipag, about 10% of patients that were on selesipag, and again, good lowering of the primary endpoint in terms of morbidity and mortality in this group of patients, and the adverse events were comparable to the placebo group. So again, repeated review and revision of the treatment, and the guidelines are quite clear in this group with regards to what monotherapy or combination therapy you can use. One of the things here is this, when they start deteriorating despite being on optimal medical therapy, it is about listing these patients for transplant if you have the opportunity to do so, which many of us in this region don't. So knowing this evidence is good, but the elephant in the room is that we are all have limited access to the drugs, and PAH targeted therapy that's available, about 13 drugs that are available in a lot of advanced centers. But if you look at Malaysia, in the public hospitals, our national drug formulary, we only have 3 drugs. And for patients who can afford, and we're a bit lucky in our institution, we have a bit more access to drugs, but we don't have IV or subcutaneous treatment. And therefore, it's not surprising if you look at our population of patients, majority of them on monotherapy. And even in this group of patients post-closure and small defects, there's about 20 to 25% who are not even on therapy. So the major impact here is the access to drugs due to cost. And the thing about medicine is it's always a double, two sides to the coin. On one end, we're discussing about closing defects, and on the other end, we are discussing about opening up defects, especially in patients where there's already evidence of RV dysfunction, and maybe as a bridge to transplant while waiting, maybe can have a port shunt, or consider an interatrial communication using these atrial flow regulators. Always have to look from the patient's perspective, because sometimes what the patient wants is not the same as the healthcare worker, and therefore having patient advocacy groups, counselors, PH nurses, and social workers are just as important in managing these patients. So in conclusion, ladies and gentlemen, today it's all about being proactive in managing these patients, early detection of these patients, timely closure of the defect is important. However, the patients have developed some degree of primary vascular disease, then again refer to expert centers, comprehensive review, consider, treat, and repair in the patients that are suitable. But all in all, those patients who have post-closure of the defect and those with small defects, then you have to be proactive to re-stratify the patients, institute PAH targeted therapy, either monotherapy or sequential upfront or even triple combination for the high-risk patients. And this backup of having a lung transplant, a heart lung transplant, is something that to be considered in these patients who deteriorate despite therapy. But I think we have to also look at other issues like long-term surveillance, contingency plans, supportive and preventive measures, and also patient advocacy and patient point of view. So the way forward, actually, I think really it's important to have a task force and registries, which many of us don't really have in this region, even nationally, because this will give us the burden of the disease and also something for us to use to change policies, collaborations within the healthcare personnel, institutions, and with the industry, as well as with patient groups are important. Education and creating awareness, not only among healthcare workers, but with the policy makers and in the community, is just as important for us to improve the care of these patients. Trying and getting involved in multi-center trials also helps in that you get access to drugs, and also it helps us manage these patients in a more constructive manner. And with that, I thank you for your attention.
Thank you, Geeta, for this insightful and informative lecture. So it is very upsetting that despite what we have done, how hard we try, the right ventricle will eventually fail. Giving medication will slow down the progression, but no doubt the RV will eventually succumb to the high pressure it has to overcome to supply blood to the lungs. And to talk about how we can salvage the RV, how we can support the RV, is our fellow colleague and friend, and importantly, our inspiration, Professor Konstantinos Dimopoulos. He is the professor in adult congenital heart disease and a professor in pulmonary hypertension at the Royal Brompton and Harefield Hospital Trust, and also Imperial College London. He is a prolific researcher. He has published more than 300 articles and has authored in multiple book chapters. And today he's going to talk about supporting the right ventricle. Over to you.
Hello, thank you very much for having me today to speak. I'm Kostas Dimopoulos. I'm a professor of adult congenital heart disease and pulmonary hypertension, Imperial College London, and consultant cardiologist at Royal Brompton Hospital, part of Guy St. Thomas's Trust. I will share my screen now and start with my presentation. I'm going to talk about the supporting the failing right ventricle in pulmonary hypertension, focusing mainly on congenital heart disease, as this is the topic of this session. First, to remind ourselves that pulmonary hypertension related to congenital heart disease is included in all 5 groups of the International Classification of Pulmonary Hypertension, from Group 1 PAH, which is the other patients that we focus mainly, the 4 groups, the Eisenmengers, the repaired, the left-right shunts, and the congenital. Also in Group 2, we've got lots of patients with pulmonary hypertension, which is post-capillary due to congenital defects affecting the left side of the heart. We've got patients with pulmonary hypertension related to lung disease or peripheral pulmonary stenosis, and also the miscellaneous group where we have the segmentals, the single ventricle patients. We're going to focus mainly on the Group 1, where the patients, for example, like this patient born with a ventricular septal defect, in whom there is significant left-right shunt and pressure volume load of the pulmonary circulation, leading to pulmonary vascular disease and increased pulmonary vascular resistance. Now, depending on the size of the defect, the location, and other factors, this can progress to Eisenmenger syndrome, which is the extreme end of the spectrum, or stop halfway into intermediate degrees of histological degrees of disease, with a moderate pulmonary vascular increases in pulmonary vascular resistance, and still left to right shunt. Regardless, the right ventricle is instrumental in the prognosis and the symptomatology of these patients, and of course, depending on the severity of pulmonary vascular disease. The survival of these patients not good, especially in the Eisenmenger population. You can see that even the adult patients who are said to be stable, still there is significant mortality of over 20% every 10 years. This hasn't changed much over the years. What has changed is the mode of death, where we see more patients dying of heart failure rather than hemorrhage or pre-procedural complications. This, for me, means that we are understanding more about this condition, about Eisenmenger syndrome, and we are allowing our patients through pulmonary arterial hypertension therapies and avoiding pitfalls to survive longer. Of course, the more they survive, the more the RV can be impaired. This is a progressive disease, and they tend to die more of heart failure or of complications from infection, for example. The more impaired the patient is, the more likely to have major complications from a chest infection, for example. Now, the RV is instrumental, as I said, in the symptoms and prognosis. This is an example of a RV in an Eisenmenger patient with a large VSD, which is well adapted. You see that it is hypertrophied, yes, to cope with the high pressures, but it's not particularly dilated, and its function is good. Compare that to the patient with idiopathic pulmonary arterial hypertension, where you see the RV is very dilated and impaired. You have raised right atrial pressures, the LV is affected, the timing, the filling time is significantly reduced. Even in the Eisenmenger spectrum, we have patients with well-adapted RVs. This is a young patient with a complete AVSD. You see how hypertrophied and contractile the RV is, and though there will be some diastolic dysfunction, as opposed to pre-tricuspid shunt ASDs, where the RV is very dilated, impaired, looking more like idiopathic. But also in post-tricuspid shunts, this is a 55-year-old with Eisenmenger syndrome. As you can see, over time, the RV, which was well adapted a few decades before, now is becoming impaired. And of course, we have the complex patients. So the presentation prognosis depends on many things, including the RV adaptation. This is also underlined by the fact that the parameters of RV dysfunction are significant prognostic markers in Eisenmenger syndrome. This is from a study from our center where a composite endpoint, composite score, echocardiographic score, which combined TAPSE, but also the systolic diastolic ratio, i.e., showing whether there is good diastolic time in tricuspid Doppler, as opposed to impaired RV with little diastolic time. And of course, combine that with the RA size, and the ratio of RA to LA was strongly predictive of mortality. Now, how do we support the RV? We said that in these patients. This is the BRIT5, which improve pulmonary vascular resistance, hence helping reduce the RV after load and increasing 6-minute walk distance. We have more data, not randomized strong data, but some retrospective, quite important data. This is an example of triple combination therapy with prostanoids, mainly subcutaneous treprostinil in Eisenmenger patients from a registry from 3 European countries, where you can see the improvements in 6-minute walk distance, in BNP, in hemodynamics. And we have also published now 12 years ago is data showing that even in Eisenmenger patients there's an improvement in prognosis with PAH therapies. People wouldn't believe that in the past there have been numerous papers from around the world confirming this data. So another reason to support the RV through PAH therapies. But it's not just about Eisenmengers. We are preparing for the future, and this is what will happen in the future in the adult services, and is happening now in the pediatric services. So this is data from Great Ormond Street. You can see that over time there has been a reduction in the white in the number of Eisenmenger patients, but an increase in the number of patients in group T, so the repaired congenital heart disease with pulmonary hypertension. So we need to prepare, and we need to be ready to treat these patients who have different physiology, who have a worse prognosis, it seems, in adult populations. This is data from from Bologna, and there have been data from the Spanish international national cohort showing the same, showing that patients with repair defects tend to do worse. Perhaps they have lost their relief valve, which was their ventricular septal defect, or PDA, by closing this, and certainly we see very often in these patients that the RV is not well adapted to the pulmonary vascular disease, as opposed to what we often see in Eisenmenger VSDs or AVSDs. The good thing about this patient, especially with simple defects closed, is that they have been included in the big randomized trials, and also the most recent ones like Seraphim and Mastentan, showing a significant, showing a good trend there for improvement in the endpoint, the clinical endpoint with Mastentan, the patients with repair congenital heart disease, and also in the Griffon study with Selexpac, showing again a clear trend for an improvement in the endpoint in these repaired patients. What we strive to do is what the guidelines tell us. This is to bring the patient from a high risk to a low risk group. Now, this table from the guidelines applies mostly to the idiopathic patients, but the principles are the same. Perhaps some of it applies to the repaired ones. The numbers I do not think apply so much to the Eisenmenger patients, but the principles are the same. You need to look for RV failure, you need to look functional class, you need to look 6 millimole distance, so exercise capacity, you need to look for hemodynamics and imaging, and to risk stratify your patients and try to improve their risk with therapies and your management. But what is this RV remodeling? What is ventricular remodeling? It is a genome expression resulting in molecular, cellular, and interstitial changes. It's manifested as changes in size, shape, and function of the heart in the RV dilatation, RV hypertrophy, RV impairment. It results from cardiac load or injury in the pulmonary hypertension, the pulmonary vascular disease, combined, of course, with tricuspid regurgitation, ischemia, etc. And influenced, as I said, by hemodynamic load, neurohormonal activation, and other factors. It can be adaptive or maladaptive. We've seen some examples where it can adapt well, the right ventricle, hypertrophy, very good function, or maladaptive, dilated, and impaired. Let's take it one step at a time. What happens in pulmonary hypertension? You have pulmonary vascular disease, which causes an increased pulmonary vascular resistance and afterload increase on the RV. And the RV, what does it do? It adapts. It adapts through hypertrophy, through homeometric adaptation in the beginning. So it doesn't dilate much, but it becomes more hypertrophied, increasing its contractility, maintaining cardiac output. This is okay. But as the disease progresses, you have a heterometric adaptation. The RV starts dilating, starts becoming impaired. It becomes uncoupled from the pulmonary circulation. So you want to have a good coupling between the RV and the pulmonary circulation. If the afterload increases, you want the RV to adapt this, or to remain coupled. There's an uncoupling in this case from the pulmonary circulation with prolonged RV contraction. We saw the systolic diastolic ratio that I showed you before, but also with increased wall tension causing myocardial ischemia, tricuspid regurgitation, ventricular-ventricular interaction affecting also the LV, and all this causes a reduction in cardiac output and increased right atrial pressure. And this also feedbacks. There's feedback. So reduced cardiac output affects RV contractility, so does hypotension, which affects myocardial ischemia and RV contractility. The right atrial pressure that increases is detrimental to the myocardial function, as we will see. So you see the vicious cycle here that is happening. How do we assess this coupling of the RV to the pulmonary circulation? Well, we would do it through pressure volume loops ideally, which combines the pressure and the volume changes in the ventricles. You can see how this is the LV-RV, how the RV in pulmonary hypertension resembles more the LV pressure volume loops. And through the pressure volume loops, we can measure this is in the case RV and systolic elastance. A little bit more difficult to assess than LV. and also the arterial elastance, so the relation between the stroke volume and systolic arterial pressure. And we get this ratio of EES to EA, which measures the coupling of the the ventricle to the arterial circulation, so RV to the PAH, to pulmonary circulation. In normal patients, this is well coupled and adapted, well adapted, so homeometric adaptation, you have again well coupled, both chains, both adapt to the changes, but then the coupling of the RV to the pulmonary circulation changes when the RV fails to adapt to the increasing pulmonary vascular disease. Now, simply said, without pressure volume loops, I want you to think about the transpulmonary Doppler in patients in two situations where you have RV pressure overload. You have the patient with pulmonary vascular disease and the patient with pulmonary stenosis. You can see that the transpulmonary Doppler is completely different, and that tells us a little bit about the coupling of the RV to pulmonary circulation. In pulmonary stenosis, even if it is severe, unless it's extreme, of course, the right ventricle becomes more muscular and can push blood through. It's like a person pushing a load through a flat surface, and the RV manages to push blood through. Whereas in pulmonary vascular disease, it's as if you're pushing through a fixed wall, and nothing much really happens, because you see that the RV pushes blood through the pulmonary circulation and hits a wall of resistance, suddenly stops, with trickling of flow thereafter and reduced cardiac output. So you see how the two situations of RV pressure overload are completely different, and the coupling of the RV to pulmonary circulation is completely different. Now, let's go back to this diagram and see what we can do to improve things for our patients. So the first thing, it was afterload increase. So whether it is the first time we see the patient or the patient presents in decompensating heart failure, what the first target would be to reduce your pulmonary vascular resistance through PAH therapies, whether new or escalating. If the patient is in extremis, you will think about starting prostanoids. If the patient is, for example, chronic thromboembolic pulmonary hypertension or peripheral pulmonary stenosis, you want to do something to abolish those stenosis through PAH or angioplasty. You want to correct the hypoxemia, which can cause vasoconstriction. And then you want to go and support the RV contractility through dobutamine or merinone very often today. And also you want to support the RV by providing with adequate preload, so adjusting the right atrial pressure. Finally, you don't want any ischemia, and you can use noradrenaline to maintain blood pressure, because the myocardial ischemia will affect RV contractility and make things worse. Now, if you have an RV which has failed, you want to optimize your cardiac output through your inotropes, through your PAH hypertension therapies, but also optimizing, as I said, the central venous pressure, the right atrial pressure. This is a narrow Starling curve. You want to keep your right atrial pressures around 10 to 12. Higher than that, the RV does not respond well. Lower than that, again, the RV does not respond to that. So close monitoring of central venous pressures. You want to look for arrhythmias. These patients do not tolerate arrhythmias, even if they're not too fast. Supraventricular arrhythmia of 100, 120 will not be tolerated well in these patients. And we know that arrhythmias are related to outcome in these patients. You want to optimize your hematinics. For example, looking for iron deficiency, and we supplement that intravenously very often, even as a Menge patient, especially when you see the hemoglobin is well below what you expect for their oxygen saturations. But also, any type of pulmonary vascular disease does not respond well to iron deficiency. Now, if you have a patient where all this hasn't worked and you still have a refractory RV failure, you need to think about your options here. You want to see whether you want to continue with conservative medical management, or you have any mechanical options. Mechanical options being supporting the circulation either as a bridge to recovering from an insult like a chest infection or something else, or as a bridge to transplantation. We often use, nowadays we use ECMO. We consider ECMO for these patients, VV ECMO, so vein to vein, or a VA ECMO, vein to artery. The VA ECMO also provides some hemodynamic support as well, but very important to remind ourselves is that we should not be engaging into this kind of support if it's futile, if there is no insult, if there is no bridge to transplantation, we should be avoiding this. Indeed, we need to engage our palliative care teams and also our transplant teams. Is very, very important. This is a paper that we published in the UK, the Champion Group, which is a group of physicians around the UK. I'm part of them, proud to be part of this group. And we focus on education and research in pulmonary arterial hypertension, congenital heart disease. And we wrote this paper on transplantation, showing that even from the beginning, from the time you you accept the patient to be under your care, whether it's first diagnosis or not, you need to treat them appropriately and keep on reassessing them, and escalating therapies and keep on reassessing, and assessing for transplantation early, not when the patient is extremis, and knowing if your patient is a transplant candidate, if they can be listed, or if they are listed, if they are advanced condition, but also work with your palliative care team for these patients. Let's take some example of RV adaptation again. This is a 33-year-old, this is idiopathic, but it's a very good example. She presented with syncope on effort. She was in functional class 4 with some peripheral edema. You can see the RV, how impaired it is. You can see the EA ratio is reversed in the transmitral Doppler, so ventricular-ventricular interaction, and very short diastolic filling time. And what we did, what I did is I just put you on upfront combination therapy, and here you can see after a few months' time, the RV has gone from a maladaptive, so heterometric to homeometric adaptation, so well-adapted RV. You can even see the transmitral Doppler has normalized here, so optimize our ventricular-ventricular interaction. There are other examples of things that can trigger heart failure and RV failure. One prime example is pregnancy. This is a paper from Beijing, the Anzen Hospital. I put this here because it's one of the most modern papers on this area. And you can see, you can see that in Eisenmenger syndrome, we had described in the past around 30% mortality. This is a little bit lower in expert hands nowadays, around 17%, but 2/3 of patients develop heart failure at postpartum. So very important to remind our patients that pregnancy is contraindicated, but if they want to proceed, this is going to affect the RV and requires close monitoring and escalation of therapies very often. This is an example of a patient. This is at 3 months of pregnancy. She had an echocardiogram. You see the RV was normal, but around after delivery, she started having syncopal episodes. You see the RV has ballooned, is maladapted to very high pressures, develop pulmonary vascular disease, which we feel pregnancy has exacerbated and has become manifest. You can see how the ventricular-ventricular interaction, again, the reversal of the EA ratio. You see the LV is underfilled and squashed, and there's hardly any filling in tricuspid Doppler for the RV. And only a few hours of dobutamine hypoprostenol, you will see here is that the RV already starts contracting much better. There's still some tricuspid regurgitation, and the patient over the days improved significantly and improved ever more. She was put on oral therapies, even managed to come off the hypoprostenol, was doing well with an RV which is much smaller and working well. So you see you have a trigger here. You could think about putting this patient on ECMO to support the RV. I said about palliative care, again, there is a paper from Champion Group. I would invite you to look at it. It's very, very important in patients with refractory heart failure, but engaging palliative care early is important. Many thanks.
Thank you, Costas, for this interesting talk. I really learned a lot. All right, coming up next, we have finished our didactic lectures. We would like to proceed on with interesting case presentation. We'd like to learn from our real life cases, and to present these real life cases, we have Professor Alisa Lim Suwan from Bangkok. Professor Alisa was a graduate of Chulalongkorn University, and she is a pediatric cardiologist, and currently she's the consultant cardiologist as well as ACHE specialist at Ramatiboti Hospital in Bangkok. And she is the director of ACHD program in Ramatiboti Hospital. And currently she's also the deputy dean. She has gone to the management of hospital. She's the deputy dean of that university. And in her free time, she's always dedicated her time to treat patients with pulmonary hypertension and congenital heart disease. Today, she's going to share with us an interesting case that we hope we can learn a lot from. Alisa, over to you.
Thank you. Thank you for having me. Sawadee ka, or good evening from Bangkok. I would like to share the case with you, and as Dr. Ling already mentioned, from Bangkok, Thailand, and practice as pediatric cardiologist. And I'm part of the adult congenital heart team and also the interventions for adult congenital heart. And this is related with the case that we have. Basically, this is the case of 16-year-old boy who was referred to us for potential transplant valve replacement because of the pulmonary homograph stenosis. And this patient's been diagnosed with totality of flow at the newborn period, and then have late closure or collections of totality of flow at the age of 9. At that time, he have VSD closure and also have the infundibulectomy and RV2PA conduit. And he been periodic follow-up by the echocardiogram after the surgery and the recent surgery before the referral. The physicians over there detect that he have pulmonary valve, the pulmonary conduit stenosis with a peak gradient of 80 with small residual VSD. So that's the reasons for refer to us for potential TPVR for the homograph conduit stenosis. And his past medical history, he has obstructive sleep apnea, his functional class 2. He's been obese, weight 129, oxat 98%, pink mucosa, normal S1 and S2 with systolic ejections murmur grade 3/6 at the left upper sternal border, no hepatomegaly. And his chest vein, myocardial normal pulmonary blood flow, but peripheral lung field seem like diminished of the flow to the peripheral lung field. And the EKG is the axis 90, right on the branch block with QRS durations 160 milliseconds. And the echocardiogram reported intact interatrial septum, TRPG or the tricuspid regurgitation is 66, estimate RV pressure 71, dilated RV, and normal RV systolic functions, TAPSI 20, RVOT aneurysm, and pulmonary homograph conduit stenosis with a peak gradient of 86, concurrent PA branch, residual perimembranous VSD with the gradient of 62, and bidirectional shunt node at that time with normal LV systolic function. And this is the echocardiogram, slightly dilated RV, and also the residual VSD, as you can see it from the right panel over here. So what's we do for the management? Basically, the patient was referred to us for the pulmonary valve replacement, the transcatheter pulmonary valve replacement, and we take a look at the data, and we work up forward for the plan for the interventions. We obtained the MRI. The MRI showed that the patients have RV enlargement, concentric RVH, And also the diastolic volume index is 153 with RV and systolic volume index 109, quite increased for both systolic and diastolic. Severe impaired RV functions, RVEF 22, T-shaped LV with paradoxical interventricular septum, evidence of RVOT aneurysm, residual VSD with the measurement of the diameter of the VSD is 8.8 and predominate left to right shunt estimate QPQS 7.1 to 1. And the valve, the pulmonary valve conduit have some restrictions narrowing the pulmonary homograph have the peak gradient of 144 and have trace pulmonary regurgitations. And this is the still frame for the MRI. The RV is slightly dilated. RVOT aneurysm, the VSD observed over here and also here, and normal PA branches. So since we have data, and so additional data that surprised us is the VSD, but it looks small by the echo. But anyway, if we plan to do interventions, we do the CAT and obtain the data. And we CAT the patients, and for the referral, the patients was referred for TPVR. So we inject the RVOT and see that the RVOT is dilated and relative size of the pulmonary valve is relatively small in comparison to the RVOT. And injections of the LV, we have the left to right shunt across the VSD from LV gram and we fill the RV. And this is the data we obtained from the CAT. The CAT, the oxygenations, we have the step up in the RV from the RA. So it's like 11 point of oxygen step up, and also the elevator or RA pressure with the mean of 17, RV pressure 67/11, PA pressure 37/20 with the mean of 28. So patients have elevated PA pressure. The mean pulmonary pressure definitely above 20 for the new definitions, or the previous definition was 25. So the patients have elevated PA pressure for pulmonary hypertension. But take a look at the WISH. We have WISH of 19. So if the patients have pulmonary hypertension from the left side heart disease, take a look at LV and systolic and diastolic pressure is 15. So the LV function is not that great, which is increased. So the situations that we have, we think that the patients have okay VSD, and probably the LV functions is not good, RV functions is not good from the MRI also. But the gradient across the valve just around 30 millimeter mercury in comparison to the echo data that we have a higher gradient than this. So what should we do? So we have to interpret and calculations as we as the congenital cardiologists do. So we calculate the QPQS is go along with the MRI data. The QPQS that we have is 1.55, QP is 3.35, and the PVR is 2.6. So in this case, the patients have pulmonary hypertension, not the pulmonary artery hypertension, because PVR is lower than 3, but the WISH is increased. So probably pulmonary hypertension from the left side or from some other causes. Then, so the reason for refer is for the valve, the pulmonary valve replacement. Shall we do it? Or we find some other thing to do? So that's the decisions that we've been discussed among our team. But with all the data, as Kita already present for the classifications or the guideline, we have residual VSD QPQS more than 1.5. So we opt to close the VSD first and then re-evaluate the patients. So our team put the device and close the VSD, and we can still see that this is the immediate after device deployment. We still have residual VSD at the time. And immediate after we put the device on to close the VSD, we still have the PA pressure of 26. That's mean PA pressure 26. with the systolic of 33, diastolic 19, RV pressure of 58/12. So the gradient come down to 25. And we think that we still would like to do separate operations if we want to do pulmonic valve. But the RV pressure a little bit lesser than 60% of the systemic pressure. So at that time, we think that should we do anything to help the patients? Probably like the left side conditions may not be that great because the LV and diastolic pressure 15, the waist 19. But after discussions, we opt to wait for the patients to see how the patients adjust his hemodynamic to the closure of the VSD. And we think that we would to wait and see and then bring the patients back for CAS without giving any treatment for pulmonary hypertension or for left heart disease or anything. After the VSD closure for 3 months, recap the patients, the PA pressure normalized, mean a little bit elevated, 19 but less than 20, so we not call pulmonary hypertension anymore, and the gradient across the RV to PA is 22. And actually the aortic pressure is increased in this case, so RV pressure is less than half systemic, so no need for TPVR. That's the main reason for referral. So in this case, this is the echo after we put the device over here and the device over here. So in this case, I want to share that this is a complex heart with residual VSD, and we think the residual VSD is small. But I think the VSD is the root cause for both pulmonary hypertension, probably relate to the volume load with the QPPS more than 1.5 and relative PS from the volume of the left to right shunt. Take a look back at the echo. It still looks small, but we usually underestimate residual VSD after surgical repair of TED. So this is one of the lessons that we learned, that we should be investigate for the residual VSD. Probably is be one of the contributing factor for all the problem. In this case, include pulmonary hypertension. And this is all I have for now. Thank you.
Thank you, Elisa, for this wonderful case. It is really enlightening to know such a small VSD can create such a big problem. So I would like to invite all the panelists. I would like to invite you to unmute yourselves and I know switch on your video so that we can see you. We would like to pose some questions and ask some simple questions if you don't mind. So we shall start off with the questions from Geeta's talk. So Geeta was talking about starting medication in patients with WHO functional class 1 and 2. So this is some question that, this is one question that always troubles us. Unlike patients with idiopathic pulmonary arterial hypertension or patients with secondary ASD with severe pulmonary hypertension, patients with congenital heart disease, they followed up, as with pediatric cardiologists, they followed up with this for a long, long time. The question is, when do you initiate treatment? Do you wait for them to have symptoms? Or do you think that we should preemptively start them once the saturation drops to less than 95, since early initiation of therapy actually, is associated with better outcome? Shall we start off with you, Kostas? What do you think?
So, with regards to when starting therapies, you're asking. I'm
Yes.
still amazed by the case. I'm sorry. I'm still amazed by the wonderful case that we just listened to. And can I just go to the case first of all, because it's so fresh in our minds. I don't want us to put any other comments before. If you allow me, is that okay, MC?
Yeah. Geeta, do you want to share that patient, that 50-year-old gentleman with
No, I think Kostas is referring to Alisan's case.
Yeah, Lisa's case is amazing.
Right, sorry.
I mean, I must say I would have gotten it perhaps wrong. So I'm quite perplexed by the discrepancy between the non-invasive investigation, both of them telling us this is severe pulmonary stenosis. The echocardiogram that you've shown us with no aliasing through the VSD, hence equalization, near equalization of pressures between the RV and the LV that you're showing us there. And then I didn't catch whether the LV size was big. It doesn't look big on the fourth chamber view. Yet this LV causing so much trouble, and also a QPQS of 1.5. I wouldn't have expected a VSD with a QPQS of 1.5 to cause such an increase in gradients across the pulmonary valve. Yet you've shown us that closing the VSD has resolved most of the issues. Also, the other thing that completely perplexes me is the right atrial pressure, which was sky high, as well as the left atrial pressure, and how it all normalized by closing the VSD. So, can you elaborate, Professor Lisa, on this? How do you explain the discrepancy between catheter and non-invasive investigations?
Sorry, I lost the audio a while ago. Can you repeat the questions, please?
So what I was trying to say is that if you have a significant shunt through the left through the VSD, you should have left ventricular dilatation. I can't remember if you said if there was a left ventricular dilatation. Number two, I was asking with a QPQS of 1.5, would you truly expect that there is enough shunting to significantly overestimate the gradients through the pulmonary valve? These are a couple of things that that a little bit perplexed me. Of course, you have shown beautifully and very elegantly that closing the VSD has resolved most of the issues, but still I'm perplexed by this.
The issue regarding the left and right ventricle, I do believe that since the right ventricle is dilated, probably like from the PR also, that seems like it's relatively make the LV is not look that big as it's supposed to be compared to the shunt of QPKS of 1.5. So probably it's just relatively look at the size of the ventricle. I kind of surprised too, because I don't expect from the echo standpoint, I don't expect that the patient's gonna have QPQS more than 1.5 up until the MRI report. And this is the trigger. Actually, we plan to do the valve, basically. I have to accept that, okay? And this is a surprise for us. And then the MRI showed the VSD, and that's why we try to pursue and then try to explain things instead of explain that the patients have multiple problems. We see that probably what is the root cause that can explain the other things that we have. And it seemed like when we tried to close it and we did it, and it's kind of confirmed our theory that we try to explain that the left to right shunt cause increased pulmonary blood flow, cause relatively PS because of the volume that increased across the valve. The valve, the homograph conduit is not perfect, it's not normal. It has some degree of PS, but increased flow also kind of overemphasize on the velocity across the valve. That's why we have the high peak gradient across the valve. And that's the thing that we try to explain in this case after we have closure of the cat, the last cat that we have.
May I ask something? I'm just curious, how reliable is QPQS calculation in the presence of pulmonary stenosis? I'm just wondering whether that could also be a contributory factor for the low QPQS that was calculated.
So what you mean that do you think that the QPQS, this QPQS is underestimated or it's overestimated?
So maybe it's underestimated because you have primary stenosis, but it may not be as severe as was initially prior to closing the VSD, but there is some degree of obstruction to primary blood flow. So maybe that's why the QPQS is not reflecting truly the degree of the shunt. But I like Costas, I also find this case very interesting because there's LV dysfunction, there's RV dysfunction, high RA pressures. And just closing the right ventricle seems to have caused so much of, closing the VSD seems to have allowed for so much of remodeling and changes. I still feel that that maybe there's more going on with this patient than just the VSD.
I think that Professor Elisa is told us that there is obviously more going on here, but amazingly, they have identified probably the main contributor to the issues, and by relieving this shunt, taking away this shunt, they have managed to improve the hemodynamics. There's still pulmonary stenosis, which will probably get worse over time. There's certainly going to be some RV and diastolic dysfunction, restrictive RV, which would probably explain the right atrial pressures. I don't think the QPQS based on the FIC calculation can be affected by pulmonary stenosis. I'm not aware of pulmonary stenosis itself skewing the QPQS one way or the other. It is very complex physiology and very elegantly presented and managed, I think, and even caught me unawares, I must say. Congratulations.
Yeah, congratulations. I would have thought of maybe addressing both the PS and the VSD at the same time, but it's interesting that you managed to identify the problem and have prevented this patient from further intervention by just closing the VSD.
I would like to forward this. I just like to weigh in on this case now. Prof. Elisa, do you think that the RV, because of the pulmonary stenosis, has caused some restrictive physiology, and restrictive ventricle, they typically does not tolerate shunt as well as a non-restrictive ventricle? What do you think? Could that be the cause of the, because you have elegantly demonstrated that the EDP for both ventricles are elevated, but once you have eliminated the shunt, the EDP comes down nicely. What's your thought, Elisa?
Well, so the simple explanation is probably just the shunt and the volume that the load, both LV and RV. The RV load is just from the PR also, apart from the VSD. So RV volume load from the VSD and also my PR. PR is actually it's more than trace. The MRI report is trace PR, but this look like MAI, but it's maybe catheter related, but the patients have MAI PR at least. So I think this is volume load, part of the volume that's why when we handle the volume load, the patients seem like the pressure, the endoscopic pressures get better.
We have a question from Jonas from the Philippines. He said that the RV dilatation via MRI shows that is clearly dilated, and wouldn't this be an indication for pulmonary valve replacement, apart from just closing the VSD? And after closing the VSD, what happened to the RV size and the function, the pulmonary regurgitation? Does it become less? Do you have a repeated MRI to look at the RV dimension?
Not yet, but we plan to do it. But we bring the patients back for the echo. And sorry, I just have the clip over here, and the echo looks okay. I just focus on the VSD, but take a look at the number. Actually, like our team would like to do the TPVR, but take a look at the number right now. The patients actually, the functional class changed from 2 to 1. And so relatively no symptoms. And the criteria for TPVR, that the gradient is 22, and the RV systolic pressure is less than 60%. So it's not indication for the PS for TPVR at the moment, but eventually in the future, we wait and follow up the patients. The time's gonna come and we're gonna pick up the right time to do the TPVR. For the PR wise, I think that by the echo, we do not see much progress of the PR. So that's why we kind of like wait and see at the moment.
All right. Certainly so. Is there any more questions? If there's no more questions, I would like to forward some questions to the panelists. One of the first questions we would like to ask is, when would be a great timing for you to start PAH therapy in your group of patients? Costas, why don't you start?
So thank you very much. So we have been having a ever lower threshold for starting PAH therapies in patients with pulmonary vascular disease, with our Eisenmenger patients. Now, always, this is a session about congenital disease-related pulmonary hypertension. We've seen there are 4 groups. For the Eisenmengers, we've got some evidence. With the repairs, we've got some evidence. And for both groups, I would have a low threshold. As I said on the chat, I don't think there is such thing as functional class 1, someone who has at least moderate pulmonary vascular disease. And for every patient, we would discuss at least monotherapy to maintain right ventricular function. We would have a low threshold for uptitrating. I know the evidence is limited, but even Eisenmenger patients, we would have a low threshold for uptitrating following various risk factors, with the idea of getting the patient from the red to the green zone, but also reminding ourselves that these are different patients to the idiopathics and we need to have different thresholds. And we don't very often put them on IV therapies in the Eisenmengers, even though we have put some patients on the IV propranolol or inhaled iloprost when they don't respond or there is progression of their disease. And at that point, we would also send them to transplantation. With the repairs, we have a little bit of a low threshold because the physiology, in my opinion, is more similar to idiopathic, and hence combination therapy. And sometimes nowadays we often consider them for select-spec treatment as well, since we have the indication for those.
Elisa, what about you? In patients with Eisenmenger, when would you start patients on PH therapy in Thailand?
Well, actually, it depends case by case, and it's depend on insurance also, as you know. Basically, in patients with universal coverage insurance, I usually start the patients when the patients become DSAT and the patients become symptomatic. That means changing functional class, probably like from 1 to 2, and DSAT below 90s. 95 is a little bit, it's going to be long-term therapy. It's hard to encourage patients to take medications when they have bidirectional shunt, SAT 95, not much symptoms. Actually, it may not be much symptom, but they did not recognize that their exercise capacity is not it's not matched to their friend, but this is what they get used to. So it's hard to convince them to take medications every single day for them. It's asymptomatic. I'm not cyanotic yet, those kind of things. But when things change, we can encourage them take medications, regular medications, and regular follow-up. And these patients in Thailand, we have patients referred from provincial hospital also. So that's the reason some of the patients lost follow-up. They cannot come to take to refill their medications regularly. So we have to have like a commitment with them, and they recognize the problem, and we initiate treatment and follow-up.
And Geeta, what's your experience? Would you start patients early, knowing that starting patients early would help them with the abnormal remodeling of the right ventricle? Would you start them early, or would you start them when they are symptomatic?
So this is also an evolution with regards to experience and access to drugs, and also communication with the patient. So like Elisa, here in this region, the problem is actually the cost of the drugs. And if a patient is well and still totally asymptomatic, like the patient I showed, he's actually saturating less than 90. So saturating around 89, 88 at rest. And when you exert, it drops to about 85. But he's otherwise claims to be very well. His 6-minute walks like 500 over. His lifestyle has not changed very much. And to advise the patients to start expensive therapy and to take it for a long period of time, you really need to be able to convince the patients. And in my personal experience now, I find using this risk stratification tables. Now we use the ESC and sometimes add on all the other parameters for Eisenmenger, and sharing that with the patient and going through that with the patient actually has made a lot of difference in terms of getting the patient on board and allowing for these patients to start treatment earlier. The other thing I think we don't do very well is in assessing the right ventricle. So I think we have to be a bit more obsessive about looking at trending of RV parameters, because sometimes these are things that are missed. And no doubt we say that NT-proBNP is a good sensitive marker, but still, really trending of the patient, monitoring them closely, and communication with the patient and sharing this information. Personally, I feel that we should be a bit more aggressive and initiate treatment earlier for all these patients. Because once the RV starts to fail and we see all these patients present late with TR, it becomes very difficult because you can continue to accelerate therapy, but you don't really get good outcomes. And I was very impressed with Costa's patient where there's remodeling after starting PAH targeted therapy, where the RV actually remodels significantly. I mean, I personally haven't seen this in our patients. If you start them late, the RV fails, you are chasing the tail end of the dragon, so to speak. So I would advocate early, but objective way of assessing these patients.
All right. Okay. So we have a question from the audience. I know, Costas, you have in Europe, in certain countries in Europe, certain centers in Europe, they do create POTS shunt to help to offload the pressures in the pulmonary arteries. Do you have any experience? What is it possible for you to share your experience with regards to this POTS shunt? Is it a risky procedure, or is something that you would encourage people to do in patients with severe pulmonary hypertension?
We don't have any experience on this at the Royal Brompton Hospital. Great Ormond Street has experience. I've spoken to Shaheen Moladina, who's the lead for pulmonary hypertension there. First of all, the fact that the POTS shunt seems to work is a reminder to us not to close defects when we shouldn't. When people are suggesting POTS shunts for patients with idiopathic pulmonary arterial hypertension. It's supposed to be physiologically better than atrial septostomy. Even atrial septostomy doesn't happen very often in Europe anymore, and because you have differential cyanosis, etc. So Shaheen Moladina has told me that they have done it in several children with mixed results. It is a very high-risk procedure because you either do it surgically with all the risk that surgery implies. Some people are suggesting we do it percutaneously, which means you get into the left pulmonary artery and use a needle to create a tunnel to the aorta. That sounds extremely scary to me, and I wouldn't suggest it to anyone. The group from Naples has identified a couple of patients in their cohort where the PDA had been partially closed or not closed appropriately, and then they managed to reopen because there was a residual shunt through there and stent it and reopen it with very good results in individual cases. At this point in time, and until we have a device, percutaneous device that can relatively safely create this tunnel, I would be very reluctant to recommend it to anyone. This is, of course, not for Eisenmenger patients. This is for idiopathic patients. These are patients who are repaired and have significant residual pulmonary hypertension and refractory to treatment.
All right. We have another question from Indonesia. It's on patients post-TOF.
Sorry, Leong, may I just add something?
Yes, please.
With regards to this not POTS shunts, but interatrial communication. I think one of the most important thing about if you attempt to do this is the timing of instituting this therapy, because a lot of times we do it quite late. When we reach end of the road and you don't have options, and for many of us, we don't have the option for transplant, then you're looking at how to salvage these patients, and then we think about doing a transeptal puncture, and now with the atrial flow regulators put this in. But my personal experience of doing this, I think we had started it last time, is that you have to do it a bit earlier in these patients before the RV really starts to fail, and you do it in a staged manner, because the hypoxia that it causes also sometimes can have detrimental effect. So you're thinking of doing this, you have to consider planning this earlier and then doing it in a staged manner in terms of interatrial communications. But POTS shunt, I don't have experience. I mean, we don't have experience.
Which brings me to this question, Alisa. I would like to forward this question to you. What do you think of creating a shunt in a pre-tricuspid area? Do you think that pre-tricuspid shunt is a very effective way of offloading RV?
Well, I don't have the experience on this. You mean that's the created shunt?
Yeah, creating a atrial shunt, because we talk about creating creating an interatrial shunt.
Creating atrial shunt is not the final answer. You just buy time and it's bridging for the transplant. So if you don't have transplant, I'm not quite sure that we do things just to palliative but we not extend the life expectancy of the patients, right? If we have all the medications we have, and then we create the atrial septum defect or do the puncture of the atrial septostomy, and with no transplantations, I don't think that is going to change much with the fate of the patients.
What do you think, Costas? What do you think about the pre-tricuspid shunt, creating a new pre-tricuspid shunt?
I mean, the idea is based on the fact that the immunological data have shown that patients with idiopathic pulmonary hypertension and an atrial communication do better than those without. And that is the whole idea. And of course, if you have an idiopathic patient and one with ASD, the ASD patient will do better for various reasons, maintaining cardiac output, perhaps offloading the RV, not as well as a VSD or a PTA, in my opinion, but at least some offloading. But nowadays, with all the therapies that we have, we do not do atrial septostomy. And as Gita said, when you get to the point where you're desperate and you've exhausted all your measures and the patient is not, it doesn't seem you will get a transplant, doing an atrial septostomy at that point is contraindicated. You cannot do it if your right atrial pressure is high and the RV has completely failed. You've missed the boat. Doing it earlier, so it's not happening. In Europe, I don't know of any center that is actually doing. I know in Mexico, I had a conversation with a colleague in Mexico, where they've done numerous of these cases and they swear by it. And maybe we need to go to these centers and look at their experience. They haven't published it, but they've done a dozen or two. So at this point in time, it's not something we do.
All right. Okay, coming up next, we have a question from Indonesia, from Professor Anna. She talked about, post-tetralogy of fallow repair and study, and the patient has pulmonary hypertension. I presume that the patient has poor arborization of lung fields. So, for example, patient post-unifocalization that we have been aggressively doing. So, would you treat this kind of pulmonary hypertension the same way as we treat patients with shunt-related lesions? Would you start them on PAH targeted therapy, or would you feel that the lung fields is not just, the lung segment is just not well arborized, no point starting any medication at all? Your thoughts, Costas?
That's a big topic. As you say, when the pulmonary hypertension is defined as mean PA pressure above 20, the main pulmonary artery. But of course, in these patients, if we're talking about Rastelli, as you call the RV to PA conduit, means this was pulmonary atresia. We know there's a wide spectrum of pulmonary atresia. You have those without pulmonary arteries or those with done unifocalization. I call the pulmonary arteries after unifocalization Frankenstein pulmonary arteries, because they're full of stitches and they look really ugly. And as a result, you have peripheral pulmonary stenosis, which will drive the pulmonary hypertension. Having said that, many of these patients have large MAPCAs, they're the pulmonary collaterals, and the areas of their lungs could have been over flooded in infancy and develop also pulmonary vascular disease. In these cases, number one, when you do unifocalization, you should not be closing the VSD to allow the RV to breathe and have a relief valve. Number two, you should do a very careful cardiac catheter to go and look at pulmonary, starting first of all with a CTPA, which is very useful in looking at the anatomy, and then going with a catheter through the pulmonary stenosis to see whether distally there is also pulmonary vascular disease. If there is evidence of pulmonary vascular disease, of course, we will address the pulmonary stenosis if we can, and also sometimes use PAH therapies in a completely empirical way In most of these patients with pulmonary atresia and the open VSD, it's all about maintaining saturations, in my opinion, of course, improving symptoms. And that's why we use PAH therapies empirically together with trying to improve the anatomy. Very difficult cases.
All right. So we have one more question coming up. This is on IV iron therapy. We haven't talked much about the use of IV iron. We know that IV iron is very useful in patients with in treating symptoms in patients with pulmonary hypertension. And how useful is this IV iron, and how often would you use it?
So who is this addressed to?
Was this?
Yeah, Gita, why don't you start it off? No? How often do you use IV iron?
So for patients, not just Eisenmenger, but for cyanotic patients, we have a very strict protocol about assessing the iron studies, not just the full blood count, but really doing iron studies for all these patients. And we are quite aggressive in optimizing iron. So we use transferrin saturations, and if we find that say the normal is like 20 and above, so the patient is hovering at about 16 to 18, then you can consider giving the patient oral iron supplements. But we know that it's not well tolerated, and sometimes patients, because of the absorption issues, it may not be very optimal. So you really need to monitor these patients in the next month or 3 months, say for example, it gives 3 months. But for those patients where the transferrin saturation is low, we are quite proactive to start IV therapy for these patients. And depending on how low it is, so sometimes you have patients with transferrin saturation of 4 or 5, and we find that just one dose of IV therapy may not be adequate. So sometimes these patients are admitted and they're given maybe 2 or 3 doses over a period of 2-3 days. And I find that it really makes a difference in terms of the patient's functional capacity and also the patient's symptoms. So we are quite proactive in looking for it and giving IV iron therapy in these patients.
Alisa, what about you then? Are you a fan of IV iron?
No, I'm not.
Right. What about Costas? What do you think?
Well, I am a little bit a fan of IV iron. First of all, because if any one of you has tried taking iron peros, it is really bad for your stomach. It really hurts. It can give you diarrhea, constipation, and already our patients are suffering enough. Why are we doing this to them? But beyond that, beyond joking about that, iron deficiency is detrimental to these patients. Of course, we will assess transfer saturations, ferritin in all our patients routinely. And if I see an Eisenmenger patient who has a hemoglobin less than what I'm expecting for saturations, let me make an example. I have a patient resting saturation of 85%. I expect the hemoglobin to be at least 20 or 200, whatever units gram per liter. If I see that they are down to 18, and they have evidence of iron deficiency, I will certainly invite them to come in to have Ferinject. We use Ferinject because it has a reduced carboxymaltose. It's called the carboxymaltose, reduced chances of causing anaphylactic reactions. And we always start with 500 milligrams, not a full gram that you would give to the heart failure or normal heart failure patients. So, and then recheck, you need to recheck your full blood count afterwards. The fear is, of course, to cause exaggerated hemopoiesis. We haven't seen that. Of course, I wouldn't take an Eisenmenger patient who is iron deficient but has a hemoglobin of 22 to give them IV iron. At that point, I would just monitor them. So it's a combination of looking at the hemoglobin, looking at the hematinics, and also, especially in the down spaces, looking at the platelets. When you boost your hemoglobin, your platelets come down. So if you have already thrombocytopenia and the hemoglobin is not too bad, I wouldn't push for the iron there.
All right. So I have one last question. But in the interest of time, we'd like to post one last question. This question is about something that we didn't talk about. It's about dilatation of the pulmonary arteries. Many times we see our patients with severe pulmonary hypertension, the pulmonary arteries are huge, like gigantic. So when should we get worried? And even if we get worried, what can we do? Costas, this question's over to you.
So we've been burnt a little bit with this. We've had patients with progressive dilatation who have ruptured and died of massive hemoptysis. I had a young man with VSD who in his early 30s who died from that. I have developed a protocol in my mind, which is not very good, very scientific. And I want to follow these pulmonary arteries. If they go above the 5 or 6 centimeters, then I will start getting worried and trying to speak to my transplant team. I have a young lady, a 25-year-old with a VSD, Eisenmenger, who has a pulmonary artery of 7.5 centimeters. She is now on the transplant list for heart-lung transplantation at Newcastle. There's nothing else you can do for this patient. You can't stent it. Where are you going to put the stent? Where is it going to land? Probably going to kill the patient in the process. You can't do bypass surgery to replace the pulmonary artery. You should probably escalate your PH therapist to see if you can reduce the pressures. That's not going to happen very easily. So I think the only option is transplantation. So when you see very large pulmonary arteries going above the 5 centimeters, you need to be monitoring them carefully with MRI probably. And if they are progressively dilating, then you should be thinking about transplantation, even if the patient is functional class 2, is doing well otherwise.
All right. I guess that's all the time that we have. We'd like to thank all the speakers for this wonderful session. We have definitely learned a lot. And thank you for spending your time sharing your experience with us. We have one last session next Thursday, and next Thursday is about optimizing the Fontan circuit, and we have interesting talks coming up. We do hope that you can join us. I'll see you next Thursday, and thank you very much for joining this session. Thank you to the speakers, and thank you to the audience. Thank you, and bye-bye.
Thank you, everyone.
Thank you. Thank you for the invitation. Nice to see you all.
Yeah,
Rita,
thanks,
Lisa,
nice to see everyone. Lisa, very interesting case. Thank you.
Oh my
Nice to
God,
see
that
you.
was a terrible case. Very difficult to
I would have
manage.
just sent the patient to, for both VSD closure and valve replacement.
I would have gotten it all wrong, I must
Yeah.
say. Well done, well done.
Very interesting.
Yeah.
Okay, bye-bye.
Bye now.
Costas, all the best. Send regards to all at the Brompton.
I will. Thank you very much.
Take care. Thanks for your
Thank you.
support. Thank you.
Bye-bye.
Bye.
Bye.